Yes, I can hear you.
Yeah, awesome. I'd just like to thank all the participants for joining this evening, 6 p.m. New Zealand, 4 p.m. Australia, that's the East Coast, and I guess that would make it 2 p.m. Perth, Malaysia time, and Indonesia, I think, would be about 2 or 1 p.m. And I'm sorry, all the people in South America. I don't know what time zone you are, but it's got to be late in the evening. So thank you very much for joining. We're looking forward to a great presentation tonight on vital pulp therapy, and we have a great speaker, Bekir, and he's just finished surgery, by the way, so worked all day. And thank you very much, Bekir, for taking time this evening.
Okay.
I'll just read your biography, Bekir. It might take a while, so sorry about that. Dr. Karabucak is the chair professor of endodontics and director of the postdoctoral endodontics program at UPenn. He's involved in endodontic courses and seminars and pre- and postdoctoral programs. He also runs selective microscope training courses for pre-doctoral students. After earning his degree, dental degree from Istanbul University School of Dental Medicine in 1993, Dr. Karabucak completed his endodontic postgraduate training at the Department of Endodontics at UPenn, or Penn Dental Medicine, in 1998, where he also received his master's in oral biology in 2002. He also earned his DMD degree from Penn Dental Medicine in 2002. His research interests include cellular mechanisms of vasodilation, very relevant to today, and inflammatory mediators in dental pulp. Dr. Karabucak has been attending Dr. Karabucak has been the attending endodontist at Children's Hospital in Philadelphia since 2005 and is a diplomat of the American Board of Endodontics. Additionally, he has lectured nationally and internationally in conferences and also serves as a reviewer for the Journal of Endodontics. And I guess that's just a start, Bekir, because there's bound to be numerous other things you've done in your prestigious life in endodontics. So without further ado, I will welcome you and thank you, and look forward to 45 minutes of presentation.
Thank you. Thank you. I will share my screen here. Can you see my screen?
Yeah, perfect. That's excellent. Thank you very much.
Perfect.
Anyway, I'll be in the background, Kabir, so just scream if anything starts to happen.
Okay, perfect. Yes. Thank you, Steve, and thank you for the invitation. I wish I could be there personally under different circumstances. However, the COVID pandemic is affecting everybody. I'm looking forward to getting into that time period that we can travel again and be all together. But today, it's our topic is vital pulp therapy. So I will talk about vital pulp therapy and the materials that we use. And during the presentation, we will see different techniques of vital pulp therapy, and we will discuss about the methodology, why and how we are doing vital pulp therapy, and what's our philosophy here at the University of Pennsylvania. But before we start, I want to share this interesting picture. We're very proud of it. This is the first class of graduate endodontic program here at Penn, and this is class of 1947. So soon, I believe next year it will be 75th year we will celebrate. There are a lot of history here in our institution, especially in endodontics. Our classes, if you look at this picture, the back row, they're all male students with male professors. Today, a change like any school, dental school in the world. I believe the majority of students are female right now, including ours. The three gentlemen, professors sitting in front, I will highlight their picture here. These are the professors' grandfathers of endodontics today. I was lucky to have two of them as professors here when I was doing my studies. The first one is, if you see my cursor, this is Dr. Stewart. Dr. Stewart was the most quiet among all. However, he was instrumental in establishing American Association of Endodontics here in the U.S. He wrote the bylaws of the association, and he was a president, one of the first presidents of the association. The gentleman in the middle, you would recognize him. He doesn't need any introduction. That's Dr. Grossman. He's the one who wrote all the initial textbooks, developed techniques and the guidelines, principles for endodontics today, what we practice. And the professor gentleman on the right side, that's I.B. Bender. If you read classic endodontic journals, I.B. Bender, Setzer articles, that is the classic. I.B. Bender was instrumental in laying the groundwork, establishing the biological principles in endodontics. And I.B. Bender actually published this article, editorial article in 1980 in the Journal of Endodontics. The same article was published after he passed away early in 2000s. But he argues in his editorial that the future of endodontics as a specialist is very important, as a specialty. Also, he talks about, which is still true to this day, that we will always have these fast, simple techniques claiming that we can do our endodontic treatment much faster and it's going to simplify everything. However, he says if we don't do research, if we don't understand biological background information, principles, we cannot advance our specialty. I always take this article as a guide when I give lectures, and I will be using, we will be talking about basic science research and correlate that to clinical principles and the clinical technique. So throughout the presentation, we will see different vital pulp therapy techniques. This will be from stepwise excavation to direct, indirect pulp capping, pulpotomies, and SVEC pulpotomies. Also, I will spend some time on new materials that we have in endodontics. Start with MTA, and mostly we will talk about endosequence root repair material. And I'll share the research results that we had in our department. I believe endosequence root repair material is the same brand name that you have in Australia, maybe New Zealand area. In Asia, could be total fill. It's the same. iRoot is the same brand, the same material, but it is sold under different names. So let's go back to the principles of endodontics, the goal of endodontics. The goal of endodontics, like any other branches of dentistry, is to maintain the oral health and the healthy function of our patients. But endodontics in specifically, our goal is to prevent and eliminate a disease called apical periodontitis. For that, we usually do root canal. We access the roots to the apex, disinfect the root canal system, seal the root canal system. And we're very successful in doing root canal treatments, and our outcome is really promising. However, part of our endodontics is to prevent the apical disease process. So we do protect healthy pulp and seal the tooth structure so we can eliminate any inflammation, infection that may occur within the root system as well. So this article, Kakahashi's article, published in 1965, most of you are, I believe, familiar with this article. This is one of the classic articles that we all learn in dental school, in endodontic school. Also, I believe this is the most cited article in endodontics and in dentistry. What Kakahashi showed in his article that the importance of bacteria in our disease process. He correlated the presence or absence of microorganisms to necrotic pulp and the disease process. In his article, in his research project, he used conventional rats and germ-free rats. In conventional rat, all the specimens that he created pulp exposure showed pulp necrosis, disease, periapical tissues 8 days after the exposure. So we always talk about this research, this article, and we emphasize the presence and absence of microbial flora in necrotic cases. However, I would like to emphasize another secondary outcome of this study, which we don't talk about it too much, was in germ-free animals. In the absence of microorganisms, the pulp had great potential to protect itself and heal itself. In 14 days, he showed that dentinal bridge was forming, protecting the pulp and isolating the pulp tissue from the exposed area. Further studies in late 60s, 70s, and 80s showed that actually when we have cavitation in enamel, isolated strictly in the enamel area, the bacteria can get into dentinal tubules, can travel to the pulpal tissue through dentinal tubules, and can cause inflammatory reaction at the cavitation site. You see the differentiation of odontoblastic layer, changes in odontoblastic layer. So even we have a cavitation in enamel, we see reaction in the pulp in these specimens. Dr. Bergenholz in 80s showed the same reaction in human teeth. But what he showed that when we remove the caries, when we remove the irritant and we seal the cavity and we see the reparative dentin sealing the open dentinal tubules and protecting the pulp tissue. And he concluded his studies showing that the pulp has high capacity to heal and repair itself with reparative dentin. However, when the caries lesion advances into dentinal, into deeper layers of dentin, or when the caries exposes the pulp, histological studies show that the inflammatory reaction is more intense and advanced in the pulp tissue. And even histological sections show the necrotic parts within that area. But histological studies also showed that when you look at the dental pulp away from the inflammatory zone, you face with healthy pulp. You face with the pulp that it's in reversible stage, that it can protect itself, can repair itself. So this is very, very interesting finding in pulp biology as well. If you read Dr. Kim's pulp biology articles, he talks about pulpal tissue really preventing the inflammatory process advancing very quickly to the apical portion, and it advances layer by layer. Always you find reversible pulp, healthy pulp, right under heavily inflamed and necrotic pulp tissue. That's why in 80s, early 90s, when we did, or when the pulp capping was proposed, the outcome was very, very unfavorable, really unfavorable. The success Bertel in 2000 show 5 years later, success of pulp capping was 37%. So as a result, because we cannot differentiate, or we cannot identify where the inflammatory process ends, where the reversible process start, the pulp capping procedure in caries exposure cases was not recommended, and the root canal treatment was recommended in those cases. And as we all agree that reversible or irreversible pulpitis cases give us the best success rate, when we do root canal treatment on those cases, we can easily reach 90% above success. So if you ask me which one you prefer, 90+% success rate, or with the pulp capping 37% success, I would agree with everybody that we would go with higher success and root canal treatment. However, if you look at the new and other histological studies, caries exposure teeth that we deem as irreversible pulpitis, they have really heavy bacterial colonization at the coronal section where the exposure is, with high concentration of inflammatory mediators. But when you go to the apical section, when you look at histologically to the root end, you see that less severe reaction with uninflamed pulp tissue with normal architecture. And histologically, diagnosis would be reversible pulpitis, and there's no necrosis, there's no really bacterial infection. So this has been always a dilemma in endodontics, especially the new modern thinking with advancement in pulpal regeneration. We always talk about why we are taking the whole pulp out when we do root canal treatment, knowing that part of this pulp can survive if we can treat this pulp. Dr. Lindy, one of our deans in dental school here, he wasn't endodontist, he was a periodontist. He used to say the best root canal filling material is the pulp, healthy pulp tissue, its own tissue. So if you think about that one, the new thinking is that, yes, great, by extirpating the whole pulp, we reach high success rates, but histologically, we know that we are taking out not only the disease portion of the tooth, but majority of the time, healthy part of the pulp. So Beyond all in 90s suggested to use the healing potential of the pulp and the antibacterial properties of the material to our advantage, and he proposed this vital pulp therapy called stepwise excavation. So we know that when the pulp is exposed, when we have the caries exposure, our success rate goes down to 37%. So what he was proposing, that in reversible cases, these are all permanent teeth with deep caries. They were positive to vitality testing without lingering. So they were really giving the signs of irreversible, not irreversible, reversible pulpitis. What he was doing, he was excavating the caries in the peripheral area. You will see it there. He would remove completely the necrotic and demineralized dentin, but where the middle portion, where the soft, wet, or discolored dentin, central, right sitting on the pulpal area, he would leave intentionally that area without touching. So his whole purpose was, I'm going to reduce the irritant from the tooth, but I'm okay with leaving a little bit of soft dentin, infected dentin in that area just to prevent pulp exposures. And I'm going to give pulp a chance to protect itself and reverse the inflammatory process. For these cases, it is important. I have to emphasize, I will keep emphasizing that the permanent teeth with deep carious lesions, Pulp responded to vitality testing within normal limits. There was no lingering to the cold. There was no history of spontaneous pain. This is an important finding because I.B. Bender, in his articles, classic articles, showed that history of spontaneous pain, unprovoked pain, really indicates the irreversible pulpitis stage. And the patients, they had no pain with the percussion. So he was placing calcium hydroxide, known to be really effective antibacterial agent, over the soft dentin. He was sealing these cavities with glass ionomer, and he was opening 4 to 8 months after the first procedure. So what he observed, that this soft, discolored dentin, wet dentin, with the help of antibacterial material, also with the help of pulp, reparative potential of the pulp, was becoming harder, much darker, and it's not infected dentin anymore. So if it was needed, he was going back in, he was cutting out a little bit more soft tissue or soft dentin, and he was placing calcium hydroxide back and wait another 4 to 8 months. And as a result, his study showed 86% success, these cases. And he had less pulp exposures. I think fewer pulp exposures was seen as more successful cases. I believe 86% success is a very good success. And he concluded that in the absence of a microbial flora, the pulp can regenerate or reform dentin bridge and protect itself. So the problem with these studies also was the material. So in those studies from 90s and 2000s or 80s, most of the time the materials they used was calcium hydroxide, zinc oxide, eugenol, IRM, dical, or the first generations of composites. The problem with these materials were they did not seal really, really well. They did not have healing potential. Calcium hydroxide, yes, killed bacteria, but did not have any healing potential, did not induce the odontoblastic cells to reproduce more dentin bridge or the secondary dentin. All those materials, they were porous. And they did not attach to the dentin the way we understand today how the composites, they bind to the dentin. With time, with function, they cause leakage. Leakage meant new bacteria introduced into that area. Also, the other problem was ongoing canal calcification. When I was in the program studying, my endodontics in late 90s, my older professors about pulp capping or vital pulp therapy would say, yeah, but what you're going to do, this canal will continue calcifying. In 10 years, 15 years, this patient will come back to you and it's going to be very difficult to find those calcified canals. Therefore, they did not recommend vital pulp therapy. Whenever we had deep caries, whenever we had pulp exposures, we all did extirpate the whole pulp and did the root canal treatment. New biomaterial, bioactive materials. We have very exciting materials now in the market. These are MTAs or the endosequence bioceramic. In general, they prevent micro leakage much better than the other materials. They have antibacterial, anti-infection properties. They attach to the dentin. This is not really chemical bonding, but this is more of a mechanical bonding that improves the adhesion more and more with time. I'm going to share a couple of slides with you later that we're going to discuss. And these new materials, they allow healthy dentinal barrier formation below the material. So these materials, they have dual outcome. If we need to summarize, they improve the coronal seal of restorations. Also, it optimizes the development of a hard tissue barrier, which is the goal of vital pulp therapy. Let's talk about the materials a little bit, mainly bioceramics. Few years ago, I'm talking about maybe 10 years ago, MTA was very successful, very popular. Everybody was using MTA. That time I was a junior faculty and Dr. Kim was my program director and the chair. He came to me and he said, Bekir, I received this new MTA-like material. He said, I'm very happy with my MTA. I'm not interested in this material. So that material stayed, I think, on my desk for a month or two. Then with my colleagues, we said, why don't we try experiment with this material? And that material turned out to be endosequence bioceramic material. So the bioceramic materials are not new. They actually was introduced after the Vietnam War. The U.S. military was trying to help the soldiers wounded and coming back from Vietnam War. The prostheses that they were getting, they were not really working well, maybe for a couple of years, and the body was rejecting those prostheses, limbs or anything placed in the body. That time, the researchers came up with a new material called bioglass, and the paradigm shift that time. The paradigm shift from bioresorbable, bioinert towards the bioactive materials. Actually, as dentists, we understand this much better than the other professionals because we place implants. And when we place implants in the bone, we want this implant to osteointegrate, bone to grow around it, and the implant to become one piece with the bone structure. So exactly the same thing. The bioactive materials, they form a surface, on their surface, a layer of apatite-like material, and that apatite-like material is allows the soft tissue or hard tissue like bone to attach to the prosthesis or this bioactive material. In dentistry or in medicine, we mostly use bioglass. However, the bioglass has a specific formula and it has a specific use that FDA and the commercial companies accepted. In dentistry, we translated that bioglass name to bioceramics. So today we don't call them bioglass, we call them bioceramics. And in dentistry, unlike the medicine, the main components of bioceramics are calcium oxide, silicon dioxide, and calcium aluminate. If you change one of the other, if you add more calcium oxide or more calcium aluminate, you change the characteristics of the material. So most of the calcium aluminate based materials, these are our restorative materials where we use them to cement our crowns. Glass ionomer cements are all calcium aluminate based. And as you know, the material acts differently than other materials that we use in endodontics. In endodontics, we use mostly calcium silicate based materials. What are they? Calcium silicate cements could be Portland-based cements, could be tricalcium silicate based cements. We call them hydraulic calcium silicate cements because these materials, they set in the presence of moisture. That's why we call them hydraulic. So what are the Portland cement based material that we use, or what is it, or what is the calcium silicate cement that we use in endodontics? Try MTA. MTA is the first generation material that we use. Actually, this is mostly Portland-based material. It was introduced, I believe I was in the program, in late 90s. Dr. Trubinejad introduced this material into endodontics. We all received samples to use in surgical endodontics. This material over the years became very popular, and we started to use in vital pulp therapy, surgeries, perforation repair, and in a lot of aspects of endodontics. This was a super material. It was biocompatible. Even our own studies of MTA show that the tissue can grow over. The sealing ability was very, very good. I believe that's why this material was very successful compared to other endodontic materials, because it sealed really well. Antibacterial properties, and the new hard tissue formed right over the material, which we never saw on super EBA or IRM type of materials. Studies, this is Bogan's study, used this MTA on direct pulp capping, showed very, very, very good response. What Bogan did, going back to our vital pulp therapy topic, Bogan took close to, I think 53, close to 55 maybe teeth, and he followed them from 1 year to 7 years. He selected these cases. They were all permanent teeth with deep caries. They were positive to pulp testing without lingering, meaning that they were vital, but when you apply cold, patient felt the cold, but not really lingering. No history of spontaneous pain, no provoked pain, and there was no apical lesion present on the X-ray. So he had pulp exposures, and he did vital pulp therapy with MTA. Why this was very interesting study? Because this was one of the first study trying MTA in pulp capping and changing that the vital pulp therapy with MTA could be very successful, unlike the studies that we saw at the beginning of the presentation, 37%. Bogan showed that overall success is somewhere 97, 98%. 5 years later, the success of maintaining healthy pulp structure and was 94%. This is a very, very good result showing the success of bioceramic materials in endodontics. This is one of my cases showing a SVEC pulpotomy. SVEC pulpotomies we do after trauma cases. When the patient breaks an anterior tooth, fractures a tooth, when the pulp is exposed, SVEC suggested that we can remove 2-3 millimeters of the pulp into the pulp chamber, and we can seal the root canal system with calcium hydroxide. That was SVEC's suggestion. And he showed successful treatments over the years. He published many articles showing that the SVEC pulpotomy, taking a part of the nerve tissue, sealing it, protects the tooth, and the tooth continues developing, especially young teeth. So this case is one of my cases. Many years ago, this patient came in after trauma. Upper central incisor was fractured, exposing the pulp. Within 48 hours, patient came to our clinic, and patient had no pain other than just pain to soft tissue because of the trauma. Cold test revealed mild sensitivity, no lingering, no spontaneous pain. Patient within 2 days had no unprovoked pain. When we did the percussion was very little bit sensitive, but this is understandable because of the trauma. The tissue surrounding the tooth was traumatized. So we decided to do SVEC pulpotomy. We removed 2-3 millimeters of the pulp with sharp diamond burr. We stopped bleeding, and we placed MTA right on top of the soft tissue, pulp tissue. And we closed with temporary filling material, and we wanted to see the patient a week or 10 days later to make sure everything was going well. This is a year and a half later. You can see really well the dentinal bridge formation right underneath the MTA seal. The more important thing, the root development continued. Initially, when the trauma happened, you see the apical portion is exposed, open, large, and the 1.5 year follow-up, the roots closed and showing the expected development of the root tip. But let's look at this intraoral picture. You see this color change. This was one of the problems with the MTA, that it stained teeth. It's, you know, if this was my teenager daughter, I wouldn't like to have her stained tooth after trauma treatment. This kid did not care. He was really active basketball player. However, you know, you don't want to have this staining in an aesthetic zone. If you look at the studies for the direct pulp capping in the literature, this meta-analysis combination of all the studies published in literature showed a very high success rate in vital pulp therapy, actually much higher than calcium hydroxide vital pulp therapies. However, the MTA had issues. MTA had a very poor handling properties. It's like sand. You mix it, it is very difficult to carry into the cavity. If you were doing surgical procedure, it was very difficult to bring into root end preparation. In vital cases, especially, it was not pliable. It was difficult to condense. it took very long time to set. It takes 4 hours to set in the presence of moisture. And I think one of the biggest disadvantages was the discoloration of the teeth. Any case, any vital pulp therapy you do on anteriors aesthetic zone would have issues with discoloration. So we come to the other tricalcium silicate based cement. This is the next generation repair materials. This is the bioceramic material. As I said at the beginning of the talk, that this is marketed in the United States, I believe in Australia, New Zealand, maybe as endosequence root repair material. The rest of the word could be iRoot, or in Europe is marketed under different name. But they are all same material, just the marketing name is different. So what's good about this bioceramic material? The tricalcium silicate based cements, they set in the presence of moisture. When the material mixed with moisture, it gets into setting reaction. As a result, calcium hydroxide is released, and the calcium hydroxide gets back into the reaction until, as a result, the hydroxyapatite layer appears and the water released. This calcium hydroxide ions and the water, this reaction continues until the calcium ion concentration is in balance, and it may take days for this reaction to complete. This is not a setting reaction. Please don't mix it up. This is just the maturing material. So why this is an advantage for us? Because that this material requires moisture to set. In endodontics or in dentistry, moisture is something that we prevent. When we do amalgams, when we do composites, historically amalgams, when we do composite fillings, we try to eliminate the moisture as much as we can, or we try to prevent moisture coming into our cavities. In the root canal system, we cannot control the moisture. It's always moist. So it takes advantage of the moisture within the dentin, this material, in the presence of water, moisture, it sets, and it creates this layer that we typically see in bioceramic, bioactive materials, hydroxyapatite layer. Where this moisture is coming from, as I said, it's coming from the dentin that initiates the formation of hydroxyapatite layer, and it improves the material over time. So, as I said, this calcium hydroxyapatite layer appears on top of the material. So this is a very friendly material or element, or the however you call it, the particles for the soft tissue to attach on. Also, I believe that's why the MTA type of material was so successful in sealing the cavities, because this hydroxyapatite layer with time continues sealing the cavity walls and preventing the bacteria coming back into the pulpal area, pulp tissue. On the material, when you wait 60 days under the SCM, you see these small particles, and in some studies, especially coming out of Japan, they define these particles as calcium or the hydroxyapatite layer, that it's typical, that it's in between sealer and the dentin, or on top of the putty material. In 60 days, in the presence of moisture, you see these small particles appearing. So why it is important, these particles? As I said, the maturity, the material takes days to mature, the material, and with the maturity, with the development of these particles, it seals, closes the gaps between the material and the dentin. Also, these particles, they go into dentinal tubules and it locks in the material. If you remember at the beginning of the talk, I said these materials, they have great binding or properties, but it is not chemical. It is more physical binding. It is these particles attaching to the material at the same time gets into dentinal tubules and it locks the material in, seals the cavity much better. So the property is the release of calcium hydroxide. As you know, we use calcium hydroxide as intracanal medicament, or in older days we use this for stepwise excavation or pulp capping. Calcium hydroxide is known to have very high pH. As a result, is a very good antibacterial material. So during the setting reaction of bioceramics, calcium hydroxide is released. That increases the pH of the material. So a couple of years ago, we wanted to see how this material and the increased pH affects the biofilm. We took a bunch of dentinal discs, we grew biofilm over, and we placed bioceramic material on top of the biofilm. If you look at these images, the green shows all alive bacteria. This is really healthy biofilm on dentinal discs. And this is 2 weeks after. I think you should look at this image. 2 weeks after, bioceramic is enough to kill most of the bacteria within the biofilm structure. And also, if you look at the dentinal tubules, the red is all dead bacteria into dentinal tubules. This antibacterial effect of the material not stays only on the surface, but also affects the dentinal tubules. If there's any bacterial growth in the dentinal tubules, it kills the bacteria within the dentinal tubules as well. So you may tell me, you may ask, like, Bekir, how can you explain if this material has very high pH, but at the same time, this material is really friendly to biological tissues? You know, high pH usually kill the cells. However, the studies, this is one of our studies done in our lab, shows great properties of this material when you put the cells on. This, I believe, comes from the bioactive part of this material. This material releases calcium ions with time, and the calcium ions, they're known to induce cell differentiation. I believe that overcomes the pH, high pH effect of this material. So if you look at these images, RRM is the root repair material, our endosequence bioceramic material. This is human bone marrow stem cells. You see the cells attaching each other, and you see the PDL stem cells. They are all connected, and this is dental pulp's papilla stem cells. They're all connected to each other. So I always tell when I talk about these topics that these cells, they are like humans. When the weather is nice, we're happy. We like to go out and connect to each other, and talk to each other and socialize. When we're not happy, we go home. We want to be alone. The cells are the same. When they are happy on a material like this, they socialize and they connect. They touch to each other. That's how we know that these are very healthy stem cells differentiating on top of the bioceramic material. Also, many years ago, we conducted this animal research where we did a lot of root end surgeries, and we used root repair material, and we looked at histologically the response of periapical tissues to this material. If you see my cursor, you see RRM, this is root repair material, and you see the hard tissue barrier, cementum-like tissue growing over the material. And this shows that this material is really friendly, induces hard tissue formation. This could be cementum when you use it for surgical procedures, or in the vital pulp therapy cases, that is cementum dentin-like hard tissue formation. So as a conclusion, take-home message, the root repair material, bioceramic material that we use today is well tolerated by vital tissue. It's antimicrobial. It is stable dimensionally. Unlike composites, composites, we know that they have shrinkage when they set. But this material, it's not only stable, with time, with maturity, actually, it locks itself into dentinal tubules much better. It's much easier to manipulate compared to other materials, or specifically MTA. Doesn't change the color. We have conducted a couple studies in terms of discoloration of this material. And discoloration of the teeth after vital pulp therapy. Root repair material is one of the safest materials to use in the aesthetic zone, as long as you control bleeding. If you have a lot of bleeding coming in, obviously this material will soak in the blood, and everything will be discolored. But if you can control bleeding, and if you put material on top of a well established hemostasis, it should not discolor teeth. And also it has dentinogenic properties that induces hard tissue barrier formation right on the material. So let's go back to our topic. As I said, I will talk about different I'll go to different directions, and we will come back to vital pulp therapy over and over again. Let's look at some cases, and let's discuss how we select our cases when we do vital pulp therapy, what's important in our diagnosis process, and how we follow these cases. So this is a example of an indirect pulp capping case. There is no pulp exposure. The cavity is really isolated within the enamel and dentin. This case was a permanent tooth with deep caries. So we select, obviously, permanent teeth with deep caries. It is extremely important to do all your vitality testing. This is called EPT if you need to, percussion, palpation, and you have to get a good history from a patient. The tooth should be vital, first of all, and it should respond with the normal limits to vitality test without lingering. When you talk about lingering, then we talk about the inflammatory process being more advanced in the pulp tissues. That's why we select our cases according to the cold test and the lingering results. And the other important thing, there shouldn't be any history of spontaneous pain. Patients should say, no, I don't have any pain waking me up in the middle of the night. I don't have any pain when I don't chew or eat, or if I don't have any pain when I drink cold. So we remove the caries completely until we come to solid dentin tooth structure. This case was one of our graduate students' case that you see on the x-ray, lower second molar. It's almost radiographically, it looks like caries exposure. Young tooth, open apices, and under the microscope, the decay looked like that. You should always expect that the pulp may be exposed during the procedure. That's why we need to work aseptically. We should take all the precautions to make sure we're not going to introduce bacteria into the cavity. That means if you need to use a rubber dam, or my suggestion to use rubber dam all the time in these cases, that's a very effective way of eliminating or keeping the saliva bacteria away from the area. The other one, using some sort of a microscope or magnification. I have, as an endodontist, I always use microscope, obviously. I always find additional details that I need to look, I need to explore. I can differentiate healthy dentin from infected or affected dentin under the microscope. This was after removing initial bulk of the dentin. There are a little bit of red spots concerning if there was a pulp exposure. So, but we have to remove the rest of the soft dentin, and slowly with slow speed or excavators, whichever you feel comfortable. I always use initially slow speed, clean the peripheral, and slowly touching the areas surfacing the pulp chamber. And when I don't feel comfortable anymore, I switch to sharp spoon excavator, and I clean with spoon excavator and clean with alcohol in between. And in this case, we were able to reach hard dentin without exposing the pulp. And this is indirect pulp capping, as studies show that we should have way above 90% success rates. And we prepared and we covered the area with root repair material. I use thick root repair material covering all the surfaces because I know this material seals really well with time especially, and it has biological effects. If there's any dentinal tubules open, this is going to affect the pulp closer to that area. On top of it, we use Fuji glass ionomer just to seal the root repair material. If you remember the beginning of the presentation, I was talking about glass ionomer cements being in the same family of bioglass. The GI cements should attach to root repair material much better than any other material. And we cover it with either another glass ionomer, or sometimes I just do my composite filling on top. Why I do my composite filling? Because at this point I know it's clean. If I need to open up, I just need to take the composite out. My goal is to seal my root repair material, my dentin, exposed dentin completely, and I don't want any leakage happening when I seal it. So this is the X-ray. The X-ray shows very close proximity of the material to the pulp, but clinically we know there was no pulp exposure, and we should expect 90+% success rate with these cases, as Beyondall in his research showed. But again, I want to emphasize the diagnosis and symptoms, very important to identify. These are all permanent teeth with deep caries, no pulp exposure, positive to pulp testing without lingering, and no history of spontaneous pain. Let's look at to another case, direct pulp capping. Direct pulp capping is done when you have you expose the pulp. This could be very little caries exposure, but very little, not too much of caries exposure, or this could be during your cleaning, you expose the pulp with your burr or with your excavator. Again, it is very important to establish your diagnosis and symptoms before doing this procedure. These are all permanent teeth with deep caries. They test positive to vitality testing without lingering, no spontaneous pain, no radiographic apical periodontitis. Young patients, even though most of the studies included wide range of patients with different ages, from 8, 9 years old to 70 years old, and those studies, they showed that younger patients, they respond much better than older patients, because they have much better, obviously, healing potential. When you have direct pulp capping, when you expose the pulp, the other indicator is the bleeding control. Most of the studies showing high success rate, they were able to control bleeding within 5 to 10 minutes. If bleeding continues more than 10 minutes, then we cannot just do direct pulp capping. We need to go to one step further to pulpotomies. And the exposure size, the studies show that any exposure less than 5 millimeter would give better prognosis. If you have larger than 5 millimeter, then we may need to go a little bit deeper, take away a small piece of assumed inflamed part of the pulp and seal it with our root repair material. This is a case for direct pulp capping. This deep caries lesion was removed under rubber dam and under microscope. Even though we were very careful, couple small excavation movement exposed the pulp. And you will see bleeding coming up, and you have to stop bleeding. How we stop bleeding, I have a couple other cases later to show, but you take a small cotton pellet, you soak with sodium hypochlorite. This is what we use. Sodium hypochlorite is very effective antibacterial agent. So I always wipe my cavities in direct, indirect, or partial pulpotomy cases with sodium hypochlorite, because my goal is to work aseptically, reduce the bacterial load as much as I can. So we place a cotton pellet soaked with sodium hypochlorite. We put pressure on the exposed area for 5 minutes to 10 minutes, and then we check. If we establish hemostasis, and that's a great candidate to do the direct pulp capping. So as you see on this image, we covered all the exposed area with RRM. Technically, I would remove a little bit of RRM covering the margin, so you can get a better adaptation of your composite or glass ionomer, and the tooth was restored with glass ionomer cement in this situation. And this is 1 week later. It is important to contact the patient a week and 2 weeks later to make sure they don't develop spontaneous pain. This is 6 months later, and this is 2 years after the initial treatment. You appreciate that the dentinal bridge formation under the bioceramic material. That shows us that we were able to maintain the healthy tooth structure, healthy pulp structure, and that had great potential to heal, block itself with reparative dentin. And now it is time to go back and restore this tooth permanently if it wasn't done already. So this video is an example how we do this. Again, under the microscope, this was a direct pulp capping. I'm going to play one more time this video. with the clean excavator, we make sure we have hard dentin, and this is the cotton pellet soaked with sodium hypochlorite. We just dab and put pressure on the exposed area. So what's the concentration of sodium hypochlorite we use? We routinely use 3% in our clinic. That is considered half strength in the United States. If you use 1% sodium hypochlorite, that's fine. If you are using full strength 6%, that is fine. As long as it is soaked, not really runny, and you put pressure on the teeth. And this is the x-ray of the same case. So after we establish the hemostasis, this is the bioceramic. You see the well-controlled bleeding, and a small piece of bioceramic putty was placed over exposed dentin and exposed pulp. We placed maybe a millimeter, 2 millimeter thick putty. We make sure it sets. This is a fast set putty that's supposed to set within 10-15 minutes according to studies. We put moist cotton pellet on top another 5 minutes until it initiates or starts setting, so we can place our glass ionomer on top of it. In this case, I would place a glass ionomer, completely seal everything, and observe this case. So direct pulp capping, again, I wish I could share studies, outcome studies with the new bioceramic material. However, the classic articles are all on MTA or biodentin. We are, as an institution, working on studies as well, following our cases. But these studies, they showed that direct pulp capping in young cases, young patients with MTA has success close to 95%. This was close to 2-year follow-up. And also this article was published in 2017. This was 1-year follow-up on MTA and biodentin cases. And this was somewhere 95%. So the direct pulp capping with biologically friendly materials, it's very successful. It's not like the old concepts that it will never work. These new materials, they seal much, much better, and they induce dentin formation on healthy pulp. How about pulpotomies? When we do pulpotomies, this could be full pulpotomy, this could be partial pulpotomy. The diagnosis is it's the same. We do these procedures on permanent teeth with deep caries. It is extremely important to do all the tests: cold, percussion, palpation, EPT if it's necessary. And these cases, they all respond these vitality testing within normal limits without lingering. No spontaneous pain. There's absence of apical periodontitis. On the x-rays, you may see a little bit of dark spots around the apices that you may question if this is apical periodontitis. This is normal appearance with these deep cavity cases. It may happen. And young patients, they respond well. We need to have bleeding control less than 10 minutes. To differentiate the previously, I said 5 to 10 minutes. This is 10 minutes. If you cannot control within 5 to 10 minutes for direct pulp capping cases, then the next step would be pulpotomies. When you go back in deeper, remove little bit pulp tissue, assuming inflamed pulp tissue, we should be able to establish hemostasis within 10 minutes. And the exposure size more than 5 millimeter. Whenever we have exposure size more than 5 millimeters, instead of direct pulp capping, we consider pulpotomy, and meaning that we take away the top layer of the pulp tissue. So this case, but pulp exposure was very large, and we couldn't stop the bleeding within 5 minutes. We decided to do full pulpotomy in this case. So we removed the pulp tissue from the pulp chamber all the way to the orifices, and then we placed some places 3 millimeter thick bioceramic material, and we sealed with glass ionomer, or as I said, if you have composite build-up materials, I prefer to use build-up material because the success really depends how well we seal these cavities, and we need to seal these cavities really well. Let's look at this case. This was a pulpotomy case from our clinic, one of our residents. We did all the diagnostic tests, and we decided to try vital pulp therapy. Why we decided to do vital pulp therapy? Deep caries, very young tooth. You still see the apices open, not mature. Patient did not have any lingering pain, and more importantly, patient did not report any spontaneous pain. We did the full pulpotomy on this case, and we followed. This is 18 months later. You see really nice dentinal bridge formation under the material, and also you see the continuation of the root development. So this shows that we maintain the vitality of the tooth. This shows that we allow this tooth to grow and mature. If you are concerned that this canal is calcifying a little more than usual, it's too thin, it will be more difficult to find the canals if you need to root canal treatment. You may choose to do root canal treatment at this point, and it would be still a successful case because we achieved what we wanted to achieve. We managed to induce the root development. So now the root canal treatment would be much, much easier to do. These are the intraoral pictures of that case where we had very large exposure, not in one spot, but we had multiple spots. As I said, more than 5 millimeter exposures. We waited to establish hemostasis, but it was bleeding more than normal. We couldn't establish hemostasis with sodium hypochlorite soaked cotton pellets and pressure, and we decided to go into deeper layers. We completely unroofed. We removed the pulpal tissue. Here you see that we reached the floor of the chamber with the round burr. This is diamond burr because you need more cleaner cuts on the pulp tissue. We went into orifices just to make sure we removed good amount of pulp tissue around the pulp, the orifices, and we tried to stop bleeding one more time with our soaked cotton pellet. At this moment, we were able to establish good hemostasis on the pulpal tissue, and this is a bioceramic material, root repair material, endosequence. Endosequence root repair material comes in a couple different formats, putty, fast set, and we used to have, I'm not sure if it's still available, we used to have the flowable one. This is flowable one that we injected, laid couple small layer over the orifices. The purpose of this is to prevent pushing the material into deeper layers. So we lay a little bit of a layer of bioceramic material, and we cover the top with the putty. I think the material may benefit if we soaked with or we apply saline soaked or sterile water soaked cotton pellet. Just wait a couple minutes to make sure the material starts setting. And now we cover with putty root repair material. If you don't have flowable root repair material, if you are using bioceramic sealer, you can use bioceramic sealer in the same with the same technique, in the same manner. You can deposit just the sealer over orifices just to create a little bit of a layer of bioceramic, and then you can add bioceramic putty 2-3 millimeters thick, and we put cotton pellet again, moist cotton pellet, and in this case, this tooth was sealed with temporary filling material to follow up and bring the patient back. So this is one more case. The pulpotomy was done. This is a partial pulpotomy from one of our residents, Mohammed. He exposed the pulp tissue. We couldn't establish the hemostasis, even though it was a small exposure, less than 5 millimeter. We couldn't really stop bleeding, and we decided to go in with diamond burr. Instead of taking the whole pulp tissue all the way to the orifices, we just wanted to remove the inflamed tissue until we establish the hemostasis. So step by step, we went in with the burr, removed a layer of pulp tissue. We applied pressure. We couldn't stop bleeding. We went back in. We removed a little bit more pulp tissue. And at this level, we were able to establish hemostasis, and we applied or sealed this whole chamber with bioceramic putty. And this is 18 months later. Actually, you can see dentin bridge formation right around the putty, around the root repair material. So this is what we're trying to accomplish. We're trying to accomplish, or what we're trying to accomplish is to create this dentinal barrier right next to the material. We want the vitality to continue. If you had open apices, we want this apices to close. Let's look at this case before we finish our presentation slowly. This was a partial pulpotomy as well. This is an interesting case because it's a permanent tooth, very young patient, no history of pain, no lingering to vital pulp therapy. We removed the cavity, and we had not complete exposure. We had small exposure sites. Instead of going all the way down to the orifices, we wanted to just take out a layer of the pulp tissue at the exposure site. The reason of doing that was, if you look at the pulp chamber, how immature and immature and large it is. So if we can maintain the bulk of the pulp, and if this tooth continues calcifying and with much smaller pulp chamber, that would be the ideal healing for us. The exposure happened. We placed bioceramic material, and we sealed well. And this is 8 months follow-up. A couple things we need to pay attention to. Look at the apical portion of these teeth. They are maturing. 8 months later, it's closing. And also you see the dentin bridge formation right below the material. The pulp chamber is calcifying, which is a good sign that we maintain the vitality, health of the pulp. So let's talk about the partial pulpotomy with the trauma cases. I think this is a good example with the bioceramic material. This was a trauma case. Patient came in, pulp exposure in the anterior, very pinpoint exposure. The other one was actually at this point pulp polyp, because patient showed up more than a week after the trauma. So we decided to do partial pulpotomy. Patient had no pain, no lingering pain to cold, not waking up in the middle of the night, no spontaneous pain, no provoked pain. It's a young patient, so we decided to maintain the pulp structure in the roots. We went in, we did the partial pulpotomy. With the burr, we went in a couple of millimeters, established hemostasis, um, and this is considered healthy pulp. When you establish hemostasis, we put bioceramic putty, and we used Fuji glass ionomer cement, and we restored the teeth. A couple of weeks later, this is a 3 months follow-up with a composite restoration of those teeth. Let's look at this, the development of this tooth, progress of this tooth. With x-rays. This was the pre-op. You can see the exposure, the root, the crown fracture of the tooth, open apices, very large pulp, and the roots. And this is after after the composite filling was placed, after the bioceramics were placed. Dentinal bridge formation 3 months later is apparent radiographically. You can see that the root continues developing even 3 months later. This is 11-month follow-up, very large dentinal bridge formation. This is the goal of our vital pulp therapy. You see the thickening of the dentin roots, and you see the closure or development of the root ends after almost a year the treatment. This is another case where we use the two different materials, biodentin and BC putty. This tooth here was treated with bioceramic putty. This is our post-operative. This is 3 months later. You see the dentinal bridge formation right and after under the material. And this is 9 months later. You see the continuation of the root development at the apical portion, indication of healthy pulp tissue within the roots. So what is the success rate of partial pulpotomies? Historical partial pulpotomies. Unfortunately, we don't have good data with bioceramic materials other than a lot of case studies or case series publications. This is Svek from Svek Pulpotomy. That's his study. But he showed 96% success rate when the Svek pulpotomy is done with calcium hydroxide. This is due to trauma, and when you have caries exposure and when you do partial pulpotomy, the success shown on scientific with the scientific articles, it was 93%. So this is a very nice success rate. Anything above 90%, we should be very, very happy. But when you have caries pulp exposures and if you try to do partial pulpotomy on teeth with pain, history of pain, or if you see any radiographic changes and you have caries exposure, the studies show that the success rate goes down to 66%. So if you do have caries exposure and the teeth with pain, radiographic changes, but the symptoms are right in between. It's lingering couple seconds, but not much lingering. Patient has some pain, unprovoked pain. You see some changes radiographically, but you really want to try vital pulp therapy. Then I would go to full pulpotomy rather than partial pulpotomy. At this point, you really want to get to the healthy pulp and seal if you don't want to do root canal treatment. But as I said, 66% success rate is not acceptable. We can reach a higher 90% with our regular root canal treatment. If you want to try still vital pulp therapy on these cases, I would do full pulpotomy instead of partial pulpotomy. Let's summarize what we have talked last 45 minutes, 50 minutes maybe. Case selection is extremely important with vital pulp therapy cases. This could be direct, it could be indirect, could be SVEC or partial pulpotomy or full pulpotomy cases. You have to follow your diagnostic tests. You have to apply cold EPT if it's necessary on the teeth to diagnose the healthy tooth structure or tooth pulp. If this is in a reversible stage, you will get best results. We do obviously pulp therapy on permanent teeth. You should have positive to pulp testing without lingering, no history of spontaneous pain, no percussion sensitivity, and young patients, they respond much, much better than older patients. Major reasons for vital pulp therapy failures. If you do have failure, or if you want to try vital pulp therapy, and if you say like when this case will, or why this case will fail, in advanced inflammatory process. So as I mentioned at the beginning of my presentation, histological studies, they show that the inflammatory process doesn't advance to the deeper layers in the root very quickly. It advances layer by layer, and the pulp could be really inflamed and necrotic next to the carious lesion, but couple millimeters below it could be completely healthy. Clinically, we cannot differentiate where that cutoff point is. Histologically, we know exactly where that cutoff point is, but clinically, we don't know. The indicators of that is hemostasis. We try to establish hemostasis. If we cannot establish hemostasis, we automatically assume the inflammatory process is a little bit deeper. The only sign that accepted and we go by clinically at this point is hemostasis. So if your case fails, most likely that the pulp tissue that you remove when you did pulpotomy or when you did direct pulp capping, the tissue facing that the carious lesion was inflamed, and we should have gone a little bit deeper to remove the pulp tissue. The other reason is failure of restoration. The older studies, the papers, they showed lower success rate because their restorative material failed, or their calcium hydroxide they placed on top of the pulp tissue did not seal well. As soon as you had exposure, that calcium hydroxide washed out with saliva exposure or the fluid exposure. But the materials that we use today, bioceramic materials, if you use 1 millimeter, 2 millimeter thick, with time, this is going to seal much, much better. As a result, it's going to give a better environment for pulp tissue to develop that dentinal bridge. And the third reason could be aseptic technique. You have to use antibacterial solutions. The solution of choice at this point is sodium hypochlorite. If you want to use 1% or 3% or 6%, it's your choice, as long as you keep it long enough and you wipe the whole chamber to disinfect the chamber. Using rubber dam definitely is part of our aseptic technique, and using sterile instruments, obviously. When you remove the caries with a spoon excavator, wipe the spoon excavator after removing the pieces. Needless to, I don't have to say that, but even the burr, when you remove the bulk caries lesion, if you know you're going to go into the pulpal tissues, maybe it's good to change the burr and use a sterile burr when you are dealing with the soft tissue. What we need to do post-operatively after the treatment. We need to follow up on our patients. This could be a week, 2-week follow-up. Usually we bring the patients back to the clinic, so we do our diagnostic tests. If we decided to put temporary filling on top of our bioceramic, we bring the patient back 2 weeks later. That time we can remove our temporary filling material and place a composite material to seal better. So you have to question your patient if the patient has any spontaneous pain, lingering pain, developing pain without provoking hurting in the middle of the night, or when they drink something cold or hot, it really lingers. Recoil test, you should do thermal test. If you don't get good response with the heat, the cold, if you do full pulpotomy with all that material that you are sealing the pulp chamber, you may not get good transition of cold sensation into pulpal tissues. You may want to do EPT. EPT would not show you the inflammatory, if there's any inflammatory process going on. It will only show you if the tooth, the pulp is vital or not. We do percussion, we do palpation. We check the status of restoration. Not maybe immediately. If patient comes back for 6 months or a year follow-up, you check the restorations. You always take x-rays, especially at 3 months, 6 months, and a year follow-ups, because that's enough to show if there's any dentinal barrier happening. It will show it's a good time if everything is going south for us to see the apical periodontitis developing on the x-ray. You check your evidence of hard tissue repair, and then if it's a young tooth, you check the evidence of continuing root development. That concludes my presentation, and if you have any questions, I'll be very happy to respond. Unfortunately, I did not turn my timer on. I don't know how long it took, but I hope I was within the limits of the presentation.
Bekir is perfect, 100%. I think everybody would be quite happy to just carry on.
Yes.
I'm not sure it would carry on into the night for you, right?
Exactly. Should I turn my screen off so we can see each other?
Sure.
Okay, perfect. Yeah, you don't need to see my background.
So Becky, that is amazing.
Yeah.
The cases that you showed in the second half there are just, I guess they speak for themselves, and the how to and the why to is really very straightforward as your presentation presented. We do have a few questions that I have got here. Let me just get these up. There is a lot of questions, but here's some that I sort of formatted for you. What age would you say the cutoff point for vital pulp therapy is?
That's a very good question. As I said, the younger is better for patients. Developing teeth, they respond really well. However, pulp, I wouldn't do partial pulpotomy or full pulpotomy on well-developed teeth. Anything above 30, 35 years old.
Right.
But I think it's a clinical judgment. If it's asymptomatic tooth, very small exposure, while you're removing the caries. This is all mechanical. I would try it. It doesn't matter. At age 70, I would still try it. The important thing is follow-ups. We have to follow up with our patients to make sure our treatment is working.
Sure. There was one comment. I don't like doing root canals. Can I substitute vital pulp therapy for root canal? I guess that comment, actually, there's more to it, isn't there? Because
it is. No, you cannot replace root canal treatment. If the pulp is in irreversible stage, needs to be extirpated and root canal has to be done.
I guess, in New Zealand, definitely in Australia, we have been taught for I guess, millennia that if you expose a pulp in a caries case, that's immediately pulpectomy. And I guess this sort of puts a different light on it because, complicated molar endodontics can be challenging. And if there is a kind of state where that pulp can be saved, not only the pulp saved and remains vital, but these challenging cases where sometimes, some recent graduates are really expected to do miracle working on some cases. Maybe in some of these cases where it sort of falls into the confines of the diagnostic bracket that you sort of mentioned, and within the age group, it may be, a sensible thing to go down that route, I guess.
You're right. You're definitely right. Important thing is the diagnosis and follow-up. These are all learning cases. And these are relatively new concept for us, as you said. Older generation in 70s, 80s, this was popular. However, they did not have good materials like we have today. Revascularization procedure actually was done in 60s and 70s, but it didn't work because they couldn't seal the tooth well with the materials available that time. Today, the revascularization regeneration procedure works really well because we have those new materials like Bioceramics, root repair material. This is a learning curve. I think more we do, more we follow, I'm sure those practitioners will learn a lot from these procedures. And it's fun. It's good part of endodontics, good part of what we do. Not everything is root canal, take the tissue out, clean, shape, and fill. As I said, we need to protect the healthy pulp.
Sure. So it's a good tool to have in your toolbox, right?
Definitely.
Another interesting question: should I use caries detectors?
I don't use caries detector. Actually, we use in the clinic with residents. Personally, I don't. The reason I don't use anymore. Recently, I changed my microscope, and it has a function that shows differently. I turn it on all the time. We have to be careful with caries detector because caries detector may show differently, but it may not be really caries. So you should use your clinical judgment. But I believe caries detector, because it changes the color, it changes your perception, and you definitely your eye identifies things that missed easily before. That's part I enjoy more than relying on, color change, this is what I need to remove. No, the color changes and I say, is this something that I need to remove? And then I use my clinical judgment.
Got it. So everybody should have a microscope with a caries detector.
I'm not selling it, but it's technology. With I'm sure the loops will have those soon.
Sure,
why not using technology to our benefit?
Why does post-op pain show my vital pulp therapy has not worked?
Yes, if patient develops spontaneous pain, I usually go by spontaneous pain more than cold, because what happens is um, a patient may lose vitality without sensing it. Then if top layer becomes really necrotic, it may not react to cold drinks and cold stimulus and linger, but the spontaneous pain will start. So one patient comes, says, hey, I'm watching TV at night and suddenly I feel this tooth acting up, then I would consider that unsuccessful treatment or approach.
It's really, really valuable there. It says, will the cavity shape size prevent sometimes doing, but I guess that's to do with the restorative.
Yes. Yeah. I mean, that's part of the consideration. If the tooth is really broken down and you need a good crown restoration, you need good buildup in it, that should be part of your decision-making process. You know, it's a continuum. Restoration part is big part of what we do as endodontists. Yeah.
Oh, then follow on for that. How long do I wait for the final? How long should I wait before placing the final restoration?
That's a very, very good question. There's no scientific data out there to show this is what you have to do. We all have to have our clinical judgment. So our experience in our clinic is, as soon as we see the calcific barrier dentin bridge formation apparent on the radiograph, this could be 3 months, this could be 6 months, we recommend to put a crown restoration on it. But sometimes we wait. I mean, those x-rays, you saw them 2-year follow-up, we still had composite build-up restoration on it. Those cases, our restorative colleagues, they are not ready to put crowns, even though they should. But that's what I would go by. As soon as you have radiographic evidence of calcific barrier and the tooth is still vital, asymptomatic, I would go ahead.
That's lovely. We'll take a couple more questions because they're coming through thick and fast. Do you use EPT in diagnosis?
It's in our toolbox. Not all the time. Trauma cases, definitely I use EPT. If I get a good healthy response with cold, I don't necessarily go for EPT. But if I need to confirm my cold test, then I would definitely go with EPT test.
Got it. There were a few more very interesting questions here. Hold on. EPT, bioceramic. I think you covered this. Can I use the sealer rather than the putty? But you were placing some sealer and then the putty on top, yeah?
Yes. The difference between these materials, not much of a components of it, the particle size. So that's why it doesn't matter.
Actually, interesting. In the New Zealand NZDA one issue back, they had an author presented some studies he did a few years back on the pulp vitality of complicated crown fractures.
Yes.
They're recorded in New Zealand because we have an accident compensation commission where all of this is recorded. So he went back and looked at the 5-year post-op vitality of these teeth. And it was really fascinating because in New Zealand, in that accident compensation group, it was quite a big group, from memory, about 1,400 teeth in that group. There was about a 50% pulp vitality post 5 years. And he didn't really sort of make a lot of comments about that, obviously, because it's hard to make comments on that sort of group. But it's interesting statistic because one would imagine these group would mostly be calcium hydroxide, some kind of pulp capping, rather than the sort of partial pulpotomy that you were sort of showing in those cases.
That's correct, and I think we need to think practical and clinically. So some of these trauma fractures may happen in young teeth, and it could be very difficult, almost impossible to do root canals on these because open apices. So if 5 or 10 years later, when the roots developed, but we lose the vitality, still it's a great thing to have. It's a success because we need to think clinically. At that point, what do I need? I need well-developed root structure so I can maintain my root canal filling material within the tooth. I know the compounds of that structure. So that still is I see it as a success.
Yeah, so that's an excellent strategy where you're planning long-term to create a successful outcome for the saving of that tooth over the patient's life.
Yeah.
There are some other questions, and I'm sorry, but I guess, Bekir, if there is anybody who wants to send you questions, they can send them to me, and I can nudge you.
Sure, that would be good. Also, I think I had my email on there. If anybody was able to catch it, the last slide. But yeah, I'll be happy to.
Well, thank you. Yes. Like, it's got to be getting late there, Bekir, and you want to get home. So thank you very much for staying after a long day.
Thank you. Thank you. It was fun. It was great. Hopefully, I can make it personally there, and it will be more relaxed environment rather than seeing 10 patients.
All I'd say is be careful because we have people from Australia, New Zealand, Indonesia, Malaysia, Costa Rica, Peru, Argentina, Ecuador, Chile, Venezuela, Nicaragua, and now Bolivia as well. So you got a lot of travel.
That's great.
So thank you again, and thank you everybody for joining in whatever time zone you're listening, and some people no doubt watching or recording. But Bekir, I really appreciate it, and look forward maybe one day to meeting you again in person somewhere.
I hope so. Thank you.
Okay. Bon voyage for now.
Bye. Thank you.
Bye.
Bye.